Good afternoon, everyone. My name is Jackie Leiser. I'm a manager at CAQH Core, and I want to thank you all for joining us for this afternoon's value-based payment webinar. I'm joined by three mics today, my colleague Mike Phillips, as well as two of our value-based payment subgroup co-chairs, Mike Patwell and Mike Allwell. Thank you both for joining us today. I'll have them all introduce themselves in just a couple of minutes, but before we do that, I'm just going to run through a few quick logistics for today's presentation. If you want to access today's webinar's materials, you can do so right now. If you want to download those presentation slides, you can do that on the right-hand side of your screen under the handout section of that GoToWebinar menu. A copy of the slides will also be emailed out to everyone in the next 1 to 2 business days, along with a link to the webinar recording. If you have any questions, you can submit them at any time throughout the presentation. You can also do this using that GoToWebinar dashboard. There is a section for questions. Feel free to do this as they arise, and we will have a few minutes at the end of the presentation to take a look at audience questions and ask our panel to answer those. So please feel free to submit when you can. I'm going to go ahead and hand things over now to Mike Phillips, who will run us through our agenda and get us started.
Thanks so much, Jackie, and thanks everyone for joining us today. We have a fantastic agenda for you, and we're really going to crash on through it. So we're going to begin with an overview of CORE and also give our co-chairs on the line the opportunity to introduce themselves. I'll then go into a brief overview of the research and the focus that led to the current initiative that we're outlining today, before giving way into more of an informal discussion about the co-chair's outlook and goals for our current work. So next slide, please, Sarah. So I want to acknowledge Naveen Maram, Vice President of Digital Operations at Centene, who unfortunately couldn't join us today, but we are thankful for his involvement and contributions. But I do want to pass it over to Mike Allwell, the Vice President of Revenue Cycle at St. Joseph's Health in New Jersey, and Mike Patwell, Principal of Value-Based Care at EdFX. So Mike Allwell, if you want to share a brief introduction and then pass it on to Mike, that would be great.
My pleasure. Thank you, Mike Phillips. And we've got lots of mics on the line. I'm Mike Allwell, Vice President of Revenue Cycle, St. Joseph's Health in Paterson, New Jersey, where we've got a 2-hospital system, second largest provider of charity care, so truly a safety net hospital in New Jersey. I oversee the traditional revenue cycle functions of patient access, physician billing, hospital billing, medical records, et cetera. But I also have the ACO, CIN, and value-based contracts under my umbrella as well. So value-based is certainly something I'm very much interested in and want to do the best for our community. Again, being a safety net hospital, we've got the poor and underserved that we take care of on a regular basis. So as we talk about equities and inclusions, social determinants of health, it all falls into my category here. Mike Patwell, moving on to you.
Sure, thank you, Mike, and good day to everyone. Thank you for joining, spending time with us today. My name is Mike Patwell. I'm a Principal Business Advisor for Value-Based Care at EdFX. I've spent the past 30 years working with health systems and payers, helping to improve communications with electronic data interchange software. These past 12 years, though, I've really been focused on my efforts in helping facilitate the move from fee-for-service to value-based care model. Back to you, Michael.
Well, thank you very much to both Mikes. And for the third Mike, I'm Mike Phillips. I'm a senior manager at CORE, and I'm lucky enough that I get to work with this team of experts to really make our work a reality. So next slide, please. And you can actually advance 2 slides, Sarah. So I'm going to give you a brief overview of really who we are at CORE. The CAQH Committee on Operating Rules for Information Exchange, or CORE, was established about 15 years ago. We have accountability and direction from our participating organizations, and through this, we develop business rules that define the effective and efficient implementation of electronic standards. CORE abides to a mission and vision to serve as an industry-wide facilitator of sustainable health information exchange. This is really achieved through the publication of operating rules that support established as well as emerging standards to aid the industry in achieving automation and interoperability. CORE is also empowered in its mission by the Department of Health and Human Services, who designated our organization as the national operating rule authoring entity for HIPAA-covered administrative transactions. Next slide, please. The CAQH core participating organizations shown on this slide, who once again we're really accountable to and work collaboratively with, represent a robust cross-section of the healthcare industry. Membership includes health plans, providers, vendors, government agencies, standard development organizations, really among others. And my apologies if I excluded you. It's really due to the breadth of participation and nothing intentional. And it should be noted that between our health plan, government, and integrated health plan participants, greater than 75% of the U.S. insured population is represented by our participating organizations. So it's really an opportunity to make a significant impact on the industry as we work to advance the implementation of electronic standards. Next slide, please. So beyond the basic definition of business rules, what are operating rules, and what are our participating organizations coming together to create? Commonly used in other industries such as banking and finance, operating rules were adopted for healthcare under the Affordable Care Act, where they're defined as the necessary business rules and guidelines for the electronic exchange of information that are not defined by a standard or its implementation specifications. This means that operating rules, which are federally mandated for HIPAA-adopted electronic transactions, cannot go outside the framework established by standards, but that they are essential in defining common or best practice implementation of standards that streamline the exchange of health information. Next slide, please. So right now we are in a rule development year at CORE after spending much of 2022 identifying opportunities through comprehensive environmental scans, as well as through one-on-one industry engagement through interviews and focus groups. Many of the attendees on this call today may have participated in those, and we're very grateful for you for that opportunity. The value-based payment subgroup, which we're talking about today, launched late last month and is really well on its way to identifying rule requirements that will eventually be balloted for approval in an all-core vote. We expect that to happen Q4 2023 or Q1 2024, depending on the status of other concurrent initiatives. Value-based payment operating rules, as you can see here, are joining a list of other rule development opportunities, including those surrounding claims, EFT and ERA enrollment data, as well as a collaborative effort between NCPDP and CORE to include more detailed pharmacy information in the eligibility transaction. You can reach out to us at core@caqh.org if you'd like more information about any of these initiatives or to get involved. Next slide, please. Now we'll step into the direct efforts that CORE and its participating organizations are undertaking for value-based payments, which was really prioritized due to the evolution of VBP throughout the industry. So next slide. Shown here is a great framework for value-based payments, which we pulled from a recent article that the Commonwealth Fund put out. And this was used as a compass of sorts as CORE and its participating organizations establish opportunities for rule development. There's a lot of information on this slide, so I just want to highlight the important takeaway, and that is the fact that VBP is laser focused on outcomes, not volume. Traditional fee-for-service healthcare incentivizes volume versus the quality or outcome of care being delivered, and value-based payments really seek to flip that focus on its head, if you will, and shift the lens across the industry to rewarding high-value care, as the name implies. Transition to this has been slower than anticipated, unfortunately, even as the industry continuously evolves use cases for value-based payments. And this is really shown through the ever lofty goals of the quintuple aim, which is shown on the right-hand side of your screen, which for those keeping track at home evolved from triple and quadruple aims to promote provider well-being as well as measures of health equity. Operating rules that bring about standardization and unify industry expectations around the administration of value-based payment can help advance its goals. And these can help by aligning technical requirements, as well as giving stakeholders the ability to generalize analyses to a broader swath of the population. So that gives them the ability to generalize to health equity initiatives, or perhaps quality improvement initiatives, or even cost saving initiatives, these multiple arms that are involved in value-based payment. Next slide, please. So collectively, CORE and its participating organizations really view operating rules as a chance to, excuse the lingo, but level up VBP, and that is what is unifying us in our mission, and can be seen as integral to minimizing the impact of three principal barriers, operating rules that is. I'm not going to go into detail on each of these, as that'll be covered more as we discuss during the presentation, but the first of these barriers really revolves around interoperability and ensuring uniform technical exchange between stakeholders. The second is data uniformity, or the ability to generalize conclusions between data sources, due to all meaning the same thing, to put it very simply. And third is program complexity. And this means that operating rules can help clarify and align requirements across value-based payment programs. And this in turn helps reduce burden on value-based payment stewards as well as participants alike, giving them all the ability to align different workflows and ensure that value-based payment program A can be fulfilled with the same workflow as value-based payment B, greatly streamlining operations and greatly reducing burdens overall. Next slide, please. From these opportunities, there really are four foundational areas for which operating rule development in the value-based payment space is being pursued by CORE and its participating organizations. The first is using the benefit enrollment transaction to standardize the collection of sociodemographic data, such as race and ethnicity, at the point of member enrollment to a health plan. We view this as the opportunity to increase data quality and integrity, which in turn can help health plans build better programs and interventions that address health inequity often experienced by disenfranchised populations and communities. The second opportunity outlined here is accommodating a standard claim submission pathway across health plans that allow providers to maximize the number of submitted diagnoses, assisting with the documentation of risk variables for risk stratification or adjustment models, as well as assisting with the documentation of social risks through the inclusion of ICD-10 codes that can often be deprioritized if providers feel limited to the number of diagnosis code opportunities on a claim, which is currently limited to 12 on a professional claim. The third and fourth opportunities seek to establish uniform infrastructures as well as semantic interoperability by aligning industry technical requirements as well as contractual definitions. We expect that this could help the industry by unifying expectations within value-based payments, in turn reducing the complexity of program administration. Again, getting back to this idea of if we can impact workflows and help unify workflows at the point of program administration, we can greatly reduce the burden on stewards and participants alike. So next slide, please. You certainly heard enough from me at this point. I know I like to talk, but I do want to turn it over to our co-chairs because they're really the stars of the show here, to speak about these concepts at a higher level and outline what the benefit of our current work is. I do want to begin with Mike Allwell, once again, VP of RevCycle at St. Joseph's Health. You know, I touched on during this breakdown the incorporation and importance of health equity in the modern healthcare environment and in value-based payment. From your perspective, Mike Allwell, what opportunities does CORE have to address health equity most efficiently in value-based design?
Well, the idea of health equity is not new. It actually lives in every aspect of healthcare for all of us all day long. In fact, justice, where we advocate for the needs of all, especially the most vulnerable, is one of St. Joseph's core values. Unfortunately, as an industry, we've got a lot of work to do in quantifying and addressing inequities. We see disparities, but in many cases, we aren't doing enough to address them. I can go on and on all day about disparities in outcomes, access, and cost, but I'll try to drive to a couple of key points. The first is the fact that we don't abide by uniform data sets. Doing so could strengthen the exchange of sociodemographic information across all stakeholders. In fact, we all collect a lot of information, much of it the same, like race and gender identity, but we don't do it in the same way in all cases. CORE is proposing to address this data problem by trying to shore up the data collection at the point of plan enrollment through the mandated X12 834 transaction. Collect that data more upstream than downstream. There are standard data sets out there that could increase the data quality integrity overnight if adopted by the industry. One of these data sets we were talking about before the call started is the CDC race and ethnicity code set that contains 900 self-reported ethnicity concepts, all of which are capable for being exchanged through a unique identifier. Promoting the widespread use of this code set, as CORE is attempting to do, could be a game changer and the accurate collection of racial and ethnic categories. The second item that we're looking at is the infrastructure rules to value-based purchasing. These rules help to streamline all healthcare transactions through modern connectivity and other minimum technical requirements that the trading partners must meet. I believe there's a real opportunity to bring non-traditional organizations, such as community-based partners, more into the loop, into this conversation through a safe, secure manner. This will help to coordinate the care and get more patients the social services that they need, especially important in my demographic. So this is what we mean when we say that the core operating rules and foundational not only to existing methodologies, but also to emerging innovations in value-based purchasing. Please let me know your thoughts.
Yeah, thank you so much, Mike. And I'm really glad that you outlined the importance to this, to the core mission of St. Joseph's Health, and really tied it back to, I think, something that I can even lose sight at the end of the day. This is all about the patient,
all about
right? All about the patient. And if we can make fixes at our level, at that technical and infrastructure level, then it's really just to have downstream positive effects at that individual level. I'd acknowledge that you hit well upon not only innovation, but the fact that there are existing methodologies that core rules can support. Turn it over to Mike Patwell. What are your thoughts about how operating rules can support methodologies like risk adjustment or patient attribution that have been traditionally identified as non-transparent at best and burdensome at worst?
Yeah, well, thank you, Michael. I believe the work that this subgroup will accomplish in this second value-based initiative will continue to build on the first one. So a commercial for anybody on the phone on this webinar who hasn't signed up to be a member of this. It's a great process. In the first one, I was a member. In this first subgroup, we were laser focused on one of the most pressing issues in value-based contract, and that was standardizing patient attribution. I feel that initial groundwork of enhancing and modifying the 270, 271 transaction set, and also creating a new 834 enrollment transaction to deliver the 834, delivering timely information and a monthly rule for the payer to push that information down to the provider, so they knew who they were working with. They knew that the member that they were seeing that day was on a value-based contract. So I think that work was really timely, and it brought some standardization in the push from a payer to a provider as far as that information. And so I'm pretty confident that this subgroup, I love that we will be addressing the submission of data this time, right? So the importance of advancing some of these value-based care models that will inform CMS, state Medicaid agencies, many of them pushing out complex value-based care contracts, that this data that can be collected from the point of service will help us in a long way as far as informing and facilitating a lot of the processes that go behind the scenes at CMS, at state Medicaid agencies, even commercial payers. So as you mentioned, risk adjustment, quality metrics, it hasn't been standard, right? It's, each new model comes out, it's a little different. So, lastly, my hopes for this subgroup is that we spend time to describe and define some of these contractual terms and methodologies so that we can hopefully build a common language, or at least break down some of those barriers of proprietary terms and methodologies you spoke of, Michael.
Yeah, really great points, Mike Patwell, and thank you for sharing those. And I think that you're hitting on something really important, is that we can advance beyond the foundational operating rules, as you mentioned, for patient attribution, which the 270, 271 rules can help identify at the point of eligibility verification, whether a patient is attributed to a value-based care model, population health model, as well as the monthly requirements facilitated through the 834 transaction. But really keen in on what you were saying is that we can really begin shifting into data submission pathways and ensuring that the industry is aligned around definitions and the like, to make sure that we're all starting on a level playing field and can begin generalizing these initiatives to a broader swath of the population. So really appreciate you sharing that input. I want to pose a question to both of you now, and really these were great and important insights. And I want to say as well that I'm very excited to kick off the rule development work with you as well. But from your perspective, as you look ahead to our rule development efforts, in 10 years from now, so 2033, what advantages did our work in 2023 introduce to the industry, and how did it advance value-based care? I know it's sort of a lofty or abstract question, but maybe you can speak, one or two sentences just briefly of like what the real advantage of this work is going to be to the industry. Mike Patwell, let's begin with you.
Yeah, no, I think, value-based payments, right? We've been trying this even before ACA came out and brought some teeth or mandate to the initiatives. They've been going on for a long time. I believe that payers, CMS and state Medicaids as payers, commercial payers, and obviously you've been spending, the past 30 years traveling across this nation with doctors and nurses. Everybody's trying to do the right thing, even patients, right? We all want better outcomes, and it's just the old model of fee for service just was, it was incentivizing the wrong, the wrong outcomes. So I think in 10 years, to answer your question, I think we'll look back and say, we were at a crossroads, some legislation, some, forward-thinking state Medicaid agencies, CMS and multiple administrations really tried to fix it, and we got there. We finally got to where the payers and the providers were interacting on a common standard data set. So I believe we're at a crossroads. I think the missing ingredient here, and other countries have found this, is that if you don't have the participation by the patients, the members that want to have healthy outcomes, you can do so much. So I'm hoping in 10 years we'll be there, Michael.
Well, I'm right there with you. Turn it over to our third mic, or second mic. I'll give myself a third spot. Mike Hallwell, what are your thoughts?
You can be number one.
No.
Value-based payments and value-based methodologies have been slow to come to the East Coast, or at least in my region. But as they are ramping up, I think the standardization of data is going to give us more and more ability to focus on communities and certain socio-demographic populations to really make a difference and address some of the social determinants of health that we're seeing in the various communities right now. A lot of the work that we're doing internally is with the managed Medicaid organizations, and collection of that data is vitally important to be able to meet the needs of the populations that we are treating. And we've got community health needs assessments, and that data flows into some of what we could be using here as well. So 10 years from now, I think we will be able to address, loftily, the social determinants of health of many of our population, much of our population.
Great. And just to, put an exclamation mark on your point, I think that's value-based care is really the vehicle and has been identified as such to advance that forward. So once again, I'm right there with you. So here's hoping for the best. Well, I'd like to thank both of you and all of the attendees for your participation and ears today as you listen. I'll ask Jackie and Sarah on the line, have any questions come in that we can help address, the three of us on the line right now?
Thanks, Mike. Sarah, if you want to pull up the slide, I haven't had any questions come in so far, but if anyone does have any, I'll give you a minute or two to submit one. But in the meantime, we did have a registrant question come in. So that question is, we struggle with patient attribution. With the introduction of voluntary alignment in many CMS programs, what are the potential solutions in streamlining this process?
Yeah, really fantastic question. I'll take a stab to it and then give the other mics a chance to answer there. But voluntary attribution is a complication, and it is somewhat of a modern methodology of attribution. You're seeing it in programs like ACO REACH, even the Medicare Shared Savings Program. I can put in a plug, as I was mentioning previously. CORE has available for voluntary adoption 2 sets of operating rules. One is the 270-271 that gives you a peek at an individual patient's attribution status at the point of enrollment, or sorry, not the point of enrollment, at the point of eligibility verification. And the second that I believe Mike Patwell and I have both mentioned is the 834 member roster rule, which compels implementing health plans to provide on a monthly basis a roster level, a reported member attribution to a value-based care contract, again, on a monthly basis. So one thing that we're going to find in this industry is there are a lot of proprietary methodologies out there, and it's probably not our space to try to override those types of methodologies. Everyone needs to be considerate of their own population. However, solutions such as the operating rules can help streamline the provision of that information. Make sure it's exchanged electronically and in a standard format so it can be used, and that expectations are clear of when it's going to arrive and how it's going to look. So I'll pause there. Mike Patwell or Mike Allwell, do you have anything to add there?
It was very comprehensive response, Michael, but I could just bring in some of the work that I've done here at EdFX with a lot of the clients that we have. Attribution is their number 1 problem issue. So having somebody voluntarily say, I'm attributed to Dr. XYZ, but in reality you're seeing a number of other doctors that the proprietary methodologies that the payer is using indicates otherwise. I think that's a struggle right now. So it's our clients are trying to be flexible, and you also mentioned that there are certain guidelines within like ACO REACH and MSSP that kind of override that. So it's attribution is truly complex, but as Michael mentioned, we tackle that. It's a optional content that could be delivered in 2 ways, through the eligibility transaction set or through the enrollment roster. So we're hoping that that'll pick up over time. And with this subgroup, I think a lot of the data collection from the point of service is really going to influence some of that attribution work.
Yeah, and I would agree with all the comments there that attribution certainly is something that we struggle with to a degree, especially with our MSSP. We see member rosters go up and down somewhat regularly. And it is a little black box sometimes where that patient gets attributed to particularly a cardiologist versus a internal medicine physician or somebody of that sort. So we have some internal fighting sometimes to, who does that patient really belong to, and trying to make the case. So it is certainly something that needs to be reviewed moving forward.
And certainly aligning that information at the point of when it arrives to us can certainly help with some of those internal fights, which, Mike Allwell, I've been part of some of those fights in my past before. They're not always the most pleasant. So I want to thank both of you and all of our attendees again. I do believe that we're at time. if you have interest in joining the CAQH value-based payments subgroup for operating rule development, you can reach out to core@caqh.org as a participating organization to be added to the roster. Our next meeting will be held on May 18th between 2 and 3:30 p.m. Eastern Time. And we look forward to adding you and seeing you there. So thank you, everyone, and have a great afternoon.
Thank you all.